Clips for Coursework. Community intervention. Locality development.
And as a community organizer, the key thing you're working for is empowerment of the consumers, or as I said, constituents with whom you're working. And I've always tried to use a locality development approach that's very much like what the Peace Corps would do. You start with the people, you start with the unmet needs that they have, and then rather than reaching out and doing for them, you teach them the skills that they have to know in order to reach out for resources and gain services on their own. Now this is hard and it's slow, but what's extremely rewarding about it is that when it works, you work your way out of a job and that constituency is able to go on and handle that issue as well as others.
Empowering clients.
A number of things. Number one, I strongly encourage them and help them to learn to advocate for themselves. I must say, when I started out as a social worker, I was very idealistic and thought I could save everyone and take care of everything. And what I've since discovered is that I can be much more effective in helping clients if I help them, enable them, assist them with learning how to advocate for themselves and function more independently instead of my doing everything for them. So for me personally, I have found it's been important to take a big step back and help them that way.
Teaching as a means of empowerment.
Part of my job is to help them to understand what's reasonable in terms of expectations, what's probably not going to happen. Another strategy is to help them to become empowered by actively participating, learning how to contact their elected officials, and if they're not comfortable with that, trying to get in touch with agencies that can advocate for a particular group or a particular population or religion. They can write letters, they can go on trips to their various state capitals, wherever they are. And I think as a social work professional, again, staying up to date myself and remaining current with some of the many, many changes that are going on out there. So we are in position to provide accurate information to students as well as to clients.
I even have gone to the cable company, and we had a program that we will bring every week an issue. It was half an hour, but that half an hour I will bring someone expert on the issue and educate the community, because education of the community is also very important.
Strengths perspective.
So you're empowering your consumers. You're using a strengths perspective. And as an organizer, another thing that I would do would be to look at each constituent. Everybody's got strengths. Some people love to be on the phone. They're going to be on the committee to make phone calls to remind you of the meeting. Someone else is an artist. They can do the brochures. Anyone who comes to a meeting is going to have a skill or a strength, and it's your job to find out what that is and to let them know about it and to encourage them, so that as they begin to see themselves as stronger and as they learn more, they feel more capable to do for themselves. This approach can work with almost any client group. If I'm working with some client groups or consumer groups or constituents, the objectives may be much smaller. But even with people with serious disabilities, there are ways that they can advocate for themselves and do so very effectively.
The charter school was designed pretty much as a family approach. If you talk to the students who are there, they see it as a large family with all the pluses and the minuses that go along with that. The responsibility of being part of a family member, but also they see the support and attention, and that when they make a mistake, we see it as a mistake that has consequences, and then we get up and we go from there, and it's not held against them. To that end, they are taught to understand and to believe intrinsically that they can be successful and they can go to college and they can make themselves into whatever they want to be. And that's just the tentative belief and the climate of the entire school from day one all the way through.
Advocacy.
Well, we actually have a lot of steps to take. And we have, between going public and requesting help and bringing the issues of the population to the public, finding support from the community activists, finding support from the politicians, and actually looking for all kind of angles that we can help get service or support for those services that we need.
Actually, advocacy is one of the areas which American Cancer Society is focused on. For example, a lot of health insurance companies, they cover mammogram for the women who are age 40 and above. But from statistics, a lot of young women, they are diagnosed with cancer today. So we are trying to work with this issue to, in order to let young women have a mammogram screening covered by their health insurance.
Increasing access to services.
Oh, we are all about social and economic justice, I have to say that. First of all, our programs are designed, and older American programs are designed especially for those who cannot afford to take care of themselves in many cases. Our country's most frail, again, caregiving people, people that need the support, economic support and programmatic support. Access is a huge thing. So those are the underpinnings that we write into, literally write into every grant application, pretty much everything we do.
I think that the why, because of its stated mission of turning no one away, I think that really says it all. We are in an environment now of shrinking resources, and it's really frightening. I mean, we have agencies just closing down. And the why is nice, too, because it's a, of course, it's thought of worldwide as recreational. And so the stigma attached to coming here for mental health help is lessened, or addictions help. So you have that going for it, but also, and primarily the fact that we really work hard to make sure we give services to people who come to us regardless of their ability to pay. That, to me, really says it all.
Well, I would say, that's kind of hard, and I was looking at those kind of macro questions, wondering, because we're pretty micro here, but, we're fortunate here. We have a lot of Medicaid clients, and they do not, Medicaid pays, I think, $25 a session. And the services that we provide cost a lot more. So we have a sliding scale. We have, people are not denied services because they can't pay. So I think in that way, we're making services available to people that otherwise maybe wouldn't be able to get them.
Social work administration. Balancing multiple priorities.
It's very difficult to be an administrator because everyone turns to you and no one is ever happy. You can't please all those groups all the time. And I think one of the things people fail to understand about an administrator is that they must spend a great deal of their time looking out of the agency. They've got to look at the community, they've got to look at the board, they've got to look at funding, and hopefully somewhere in there they're looking at consumers and potential consumers and unmet needs. So a high percentage of their time might be spent out of the agency at meetings, sitting on boards of other agencies and doing other things physically outside the agency. Then within the agency, if it's running well, there's usually a strong assistant director who's doing a lot of the day-to-day work within the agency, working with making that run well. But the administrator, whoever they are, also has to listen very carefully to the staff and to the consumers and to the funding sources if we want to stay in business, and to the community who might give us sanction to continue what we're doing, and try to juggle all of those competing demands and come out at a level where the demands of all groups, not just the demands of the funders, are met. If I have a staff that's unhappy, the services the clients get are not going to be good. And if I have clients who are unhappy, then we're not getting the services that address their needs, then I'm not doing what I'm there to do. So you got to keep them all happy.
You take that job knowing that you have a responsibility to your community, to your clients, to your employees, and to yourself. Because you were not there, you have to really recognize that the employee have some insight that you don't have, and vice versa. So you have to create that line within you and the employees, and also be aware of your community. The community becomes part of your family. You have to know what is going on and how problems are impacting them, and where to go to help them, and develop new programs if it's necessary.
Using statistical data in needs assessment and planning.
Research is an extremely important skill in needs assessment for anything that you're doing, from working with an individual client, with a group, with a community, with an organization, all the way up to social institution, national and international. There is a lot of data that we have, that we collect, that we don't use. And we should look at it. We should find out what the problems are. Many of them are documented already, what the needs are. And if those data don't exist, to go out and gather that information.
Really, we are going to double our senior population in 2020 to 70 million people. And a large portion of that number will be over the age of 85. So while we'll be aging, hopefully healthier, on the route to that, there is still going to be this doubling. And that is going to create a whole array of services, a whole new way of looking at how we keep people healthy, and what kinds of ways we can help people know what there is out for them, so that along that route they are able to, if you will, perhaps use the grocery store concept, go to whatever grocery store in whatever aisle they need, and then pick out what size or what flavor they like, what's going to suit them better. It's kind of like ice cream flavors. You know, we all don't like chocolate and vanilla, and some people like to mix it up, but I think that's what we're in the process of trying to create: options. Options that are consumer-driven, consumer-directed, consumer-friendly, that are easy to access.
Designing programs to address consumer needs.
The school was designed to be a college preparatory school, but we understood that the students were going to be coming in with a variety of issues that had to be dealt with in order for us to be successful with that. Academically, they're coming in several grade levels below where they should be, but socially they're dealing with all sorts of issues. By anyone's definition, they would be certainly considered at-risk students. They're economically disadvantaged. They're coming from single-parent homes, often living with family members other than their mother or their father. A variety of issues that come, violence in the area, violence in the homes, children of abuse. So we wanted to structure the school to support the students in all areas so that they could be academically successful.
Serving populations at risk.
Our students were selected by a lottery, but the area from which we're drawing from is a very high needs area. They're coming from an urban environment. 70% of our students qualify for free or reduced lunch. And we understood when we were opening the charter school that these were the students who would be coming to us. So we intentionally structured the school to support and meet those needs. We didn't have a blind eye as to what we were getting into. Some students, some community members will say, well, it's an at-risk school. No, it's not an at-risk school. We just happen to serve an at-risk population. But we tend to look at all teenagers as being at a very volatile and difficult time in their lives. And so in that respect, they're considered all to be at risk.
Facing financial challenges.
Probably the greatest challenges are financial. We have a longer school day, a longer school year. Our teachers are in there for 8 hours a day, and then they're still taking work home like all educators and social workers and professionals do. And just to compensate them appropriately for that, to be able to run the support programs that the students need, it's definitely financial is the biggest obstacle. And we have a lot of dedicated professionals who are working there because they believe in what they're doing and care about what they're doing. And it's really a case where their avocation is their vocation, because they certainly couldn't be paid enough for all the time and effort and heart they put into their jobs.
Building on best practices.
My co-founder and I had both been teachers in Asbury Park High School, where our students would normally attend, had they attended traditional public school instead of the public charter school. And there we had been involved in various aspects of reform, from school effectiveness training to faculty councils, and run various activities for the students. Through that, we had visited different schools throughout the Eastern Seaboard and looked at schools within schools, smaller school programs. We visited other schools on our own, and what we did was we gleaned different programs and practices from those various schools that we visited and tried to tailor it to what we knew were the needs of our students, having worked with that population for so long. And then we did identify the Comer School Development Program as fitting right in with our philosophy and tied that all in together.
Continuous learning.
Learning is an everyday process. It's a personal process, and it's absolutely a process for organizations. Probably one of the things that I think is most important for any organization, and it's a little hackneyed phrase right now, but I think it's always been true, and that is to be a learning organization. So it's interesting that you pose that question.
Responsibility and accountability.
Today it's very difficult because, number one, you have, the R and the A word, responsibility and accountability. Who's responsible and who's accountable? You're responsible, but they're accountable. If you're the licensed person, you're accountable and they're responsible. And that is really a tough road to hoe, because where do they stop and you start? So a couple of things, I guess. One is really knowing your practice act, knowing where you stop and start, knowing what the practice act tells you about that, and having more than a working knowledge of team members and where they stop and start. I think that's essential to supervision.
Importance of clear communication.
Really, you are responsible for the acts of the team, the direction you give them, the clarity of your communication. Those are the big three. What is it that you are holding them accountable to do? How do you communicate what that is? And ascertaining their understanding of that feedback loop that goes in communication. I think that's one of the big flaws of supervision. It's like the fundamental thing in communication, but it's something that professionals just don't do well. It just doesn't become, again, because we're so used to talking to people and talking to others that we don't elicit from them what we told them. And that really is the essence of supervision. Is there understanding between what I told you or what we discussed and what you heard?
Comparing administration to direct services.
The closer you get to clients, patients, whatever you consumers, the better it feels. And it's really interesting because the longer you stay in a profession, as you mature in the profession, you sometimes find yourself further away from them. But it's almost like the inversely proportional relationship, if I can say that. As you get further away, you may find yourself in positions where you're affecting inversely greater numbers of people. You may, in an average day as a social worker, meet with 5 families, 10 families. Let's say even interacted, you went up on a couple of floors. If you're the executive director of the Board of Social Work in the state of New Jersey, you have thousands of social workers. You sit at a table and you create regulations that are going to affect the practice of every single person. Multiply times every person they will ever talk to for all the years that they will ever practice. Most professions don't get a chance to do that.
Burnout. Definition of burnout.
I think burnout is like something come together at the same time and you just can't take it, and you feel distressed, angry, and anxious.
I work with a lot of teachers that wind up yelling and screaming and hollering, and the kids pay them absolutely no attention. So I think it's how they approach their lives and the people with whom they interact. And I think that when they allow those students to impact on them negatively, or they see the students as negative, that becomes the core for their burnout.
Well, burnout's complicated too. I mean, we all have bad days, but sometimes overwork, working with too many trauma survivors, long hours. I mean, that's where it gets back to taking care of yourself. Yeah, I've seen it. I felt some of it. Some of it's compassion fatigue when you find yourself judging your client too much, understanding countertransference and things like that, knowing when an issue is triggering you and you've got to take it someplace else to work on it.
What is burnout? Burnout's real. Burnout is an array of symptoms. It's like a lot of other diseases. Not as simple as cancer and something else that you can take an x-ray for. Burnout is insidious. Burnout sneaks up on you. Burnout, I think all professionals, especially healthcare professionals, experience it.
One of the things that I have seen in colleagues and was pointed out to me is when colleagues start coming in and they are very grumpy, I don't mean once in a while, and you look at them and you know you don't even want to ask this person how they are. The stress really builds in people, and to me burnout essentially means that the stress level becomes unmanageable, and it reduces a worker's ability to be effective and help others. And it also reduces their ability to feel personally competent with what they're doing.
It's real, and I think every professional experiences burnout. I think burnout is caused by a couple of things. One, poorly prepared professionals. And I think the reason there was so much burnout and that it became a syndrome in and of itself is I think the education system in part failed professionals in that the educational preparation was not keeping up with the environment they found themselves in once they graduated. And they were overwhelmed by the responsibility and accountability for the lives of other people and feeling their hands tied, kind of handcuffed and helpless in many cases. And I think the literature would support that. Second thing that causes burnout is fatigue. Overwork, literally overwork. Most fatigue is caused by mental. That's obviously true. Everybody thinks it's from physically running around, but you get more fatigued from mental fatigue than physical fatigue. When you work in the healthcare professions, you're both doing something physical, in particular if you're a nurse, physicians like that. But there's a lot of mental work, especially around social work and nursing, those kinds of things, interacting with families. So you are very fatigued. And then now all Americans have a very long day. You know, you're working parents, you're working mothers, you're working 2 jobs, you know, you have a lot of responsibility, traffic is a nightmare, whatever. It's all those things. You're fatigued, you go to work fatigued, you have all this stress, you go home, it never ends. And then they call you up and want you to work an extra day, stay longer, more priorities. So burnout is not a figment of someone's imagination. It's really an induced disease. It's an environmental disease, and it's caused by a bad environment, bad professional environment, bad work environment.
Social workers who were fairly young and idealistic had higher incidence, more difficulty with burnout. And it was not until they became a little more seasoned, got to experience more seasoned, skilled social workers around them to see how they handled and managed the stress, because the work we do can be very stressful sometimes. I did run across some research that indicated that there was a higher incidence among some of the young white female social workers, which I found interesting. What I discovered with some of the social workers, the young social workers of color, particularly African American, the feeling seemed to be that we've been dealing with stress since the beginning, and that people appear to have found, at least the people I was looking at, appear to have found remedies or strategies to help them cope with stress at work, because they appeared to be indicated they were used to dealing with stress in multiple areas of life.
Personal strategies to avoid and cope with burnout.
I guess my first experience with burnout that I didn't even really recognize as such was in the child welfare agency where I started my career. And you're working with very difficult families, and the cases don't all have happy endings. So what we used to do, and I think this is important for students to know about, students misread this when they see it. We would come in, all of us who were social workers, at the end of a very hard week and laugh about clients. And we weren't laughing at them, but it was a kind of humor that agencies have. Oh, did you hear the one about the daycare mother who had this, that, or the other problems? And we would make up a joke. And I remember a student was there and said, oh, this is awful. But for us, it was a tension release. We didn't mean it. It was just a way to get rid of those bad feelings we'd had throughout the week. And I think people in agencies use humor that way. And a student coming in, if you hear that, you know, I mean, it might be what you think it is, but it might be a tension release that people are doing so that they can laugh and then go out and deal with that same issue on a reality level the next day, which we would then do.
And the way I deal with this situation is I just try to calm down and to put everything in order and to see which one is priority, which one is secondary, and just do it one by one, and then the work will become smoother.
In this field, you're dealing with people that are in distress, and you have to make sure that you are able to keep yourself out of their distress to a degree. And so you have to take care of yourself, and you have to know when you need a break, know when you need a vacation. It helps to have supportive colleagues and people that you can talk to, and supportive administrators that also understand about a therapist's mental health. And if you take care of yourself and have a good group that you work with, I think that really helps to alleviate burnout.
I think it's important to maintain your own diet and exercise, take vacations, do other stuff. I mean, it's really good for anybody that's working with people that are in a lot of pain and need a lot of support.
Certainly, I think that this profession requires more of the individual practitioner, requires more in terms of self-care, and really demands self-care. And because I think that's also something that we teach, that it's, you know, it's essential to practice accordingly, which really means, you know, having ways to relax, to cope, maintaining a reasonable diet, exercise. I mean, I hate saying all this stuff because it's so trite, but you know, it's the only thing that keeps you fit in this environment. And if you're not, it's like in the family. If you're not taking care of yourself, you're not taking care of your kids. If you're not taking care of yourself, you're not taking care of your clients. So I consider that it's the #1 responsibility of each of us. And when we cut corners, which of course we all do, and of course I've been burned out, but we know it. I mean, we feel it, and it's that much more important for us to get, you know, back on the horse.
The work of a social worker can be very stressful, and you can burn out if you take things personally. You have to understand that being a social worker is trying to help people, but it's not you, and it's not your family. You're going to treat them like you want to be treated, but you also want to be able to be detached. And we have to learn to set limits. Someone told me once, social workers don't know how to say no. And I say, I understand what you're saying, but you still have to say it. It comes to a point that you have to say, no, this is my limit and I can take more.
I would take the symptoms and signs that I just mentioned and encourage particularly students to modify expectations, to recognize and accept early on that we cannot be all things to everyone. It's a big mistake. We cannot solve all the problems of the world, and once you accept that, life will be so much easier. And I tell them I'm not kidding when I say get a hobby or have something to do outside. And I said there are a lot of free things that you can do when students or people say, oh, I don't have the money. There are too many things that people can do just to relax, like taking time out for themselves when they get home, including parents who have young children. I said, listen, everyone can learn that this is mommy or daddy's time. And when you come home, you need a little time to yourself. And another strategy that I have personally found helpful and have seen colleagues do is to learn how to decompress before you even get home. Sometimes it's a good idea. Maybe we can't do this every day, but to walk a little, I know for myself, I love just walking around the stores looking. I don't have to spend a dime, but it's a way to decompress so that when I get home, the people who I love and care about don't have to listen to all the stress of my day.
So as a practitioner, if you feel yourself wanting to pull away from your clients and that's what your job is, it's time to take a break. Whether it's a vacation, a night off, reading your favorite book, going to the movies, whatever your break is, it's time to do that when you feel you just can't look at another client.
I don't believe in burnout. I feel that I have to do, and I just do it. One day at a time. That's a little saying from AA, Alcoholics Anonymous, Narcotics Anonymous, and I utilize that. I have a job to do, and I do it. And I like what I do, so I don't feel as if I burn out. I take a vacation once a year and get away, but I'm a social worker, and I'm a social worker even when I'm on vacation, unfortunately. But that's what I do, and that's who I am.
Agency strategies to avoid and cope with burnout.
In terms of cure-alls for burnout, I don't think there are any. I think the biggest thing that you can do as an organization or as a professional is support, is recognizing burnout when you see it and not ignoring it. And that is a fault of management or a function of management. First of all, it's about the relationship between management and the worker, between supervisor and the person they supervise, or between subordinates and superiors. It's about that relationship. Is that relationship solid? Is there trust there? Is there recognition? Is there good communication? If you have that, burnout happens less. People will go the extra mile. They don't feel like they're doing it for nothing.
We've done a couple things. One of the minor things we've done is we have a book called Small Steps, and we ask the teachers to write in their little successes. So when someone's feeling like the entire day was a failure, it reminds them of their own successes that may have happened on another day, or something that went with one of their students perhaps in another class, that they can see that all together we're being successful. We also try to provide some mental health breaks for the staff and give them support. There's been days where it's been half days for the students, and the in-service is really a mental health in-service. Let's socially go do something or just relax, because it's really important for everyone to support each other personally, so that then we can work effectively.
Social welfare policy and services. Implementation of policy.
And through the Older Americans Act, which, by the way, is probably one of the most interesting things that a lot of people don't know, it is the single longest continuously renewed piece of legislation in our country outside of Medicare and Medicaid. And in a lot of ways when you read it, it's very heartening. I think that's where the learning is. It's kind of like the Constitution. When you read it now, it's more relevant now than when it was written almost 40 years ago. So what we're learning is to build on those initial principles: independence, dignity, and choice for seniors and for their caregivers. And in the case of New Jersey, we have taken that network, and we have used that network and those counties and the providers in those counties and stakeholders, and we have worked with them on, specifically on grants and in specific design of programs that they administer, but that centrally we work with them either to design, to pilot, to use as demonstration programs. And then we take what works and do it more. And we try to stop doing what we're not doing well.
Evolution of policy. And
I think what the federal government is looking at is they are looking at lessons learned from the acute care side, and from the reimbursement side, and from the quality side, and I think they are going to begin to ask us to examine some of those models and adapt them for future programs for seniors. So I think there's a huge learning curve. We're just embarking on it. I think it's a pretty steep incline, frankly, having been in healthcare quite a while. And the next biggest one is also one that's happening right now, and that is that our governor issued an executive order that is going to create a Bill of Rights for seniors, getting rid of the red tape in terms of fast-track eligibility, make it easier for people to become eligible for program offerings, a global budget, which means we need to look at a new fiscal system for enabling us to administer programs in a much more cost-efficient way, and a rebalancing effort, which means we would look at the dollars that are spent for long-term care, nursing home care, which represent the largest part of any state's Medicaid budget, and move some of those dollars ultimately for home and community-based services. So actually you'd have a much bigger shopping bag to go to the grocery store with.
Gaps, duplication, and fragmentation in policy.
And as you begin to look at the laws, you realize that laws are written piecemeal. We have an emergency, we write a law. We have another emergency, we write a law. It's kind of like a patchwork quilt, except the pieces don't fit. So as you begin to look at policies, you'll find policies in conflict, and you'll find when you get to the level of where policies talk about services, you'll find fragmentation of policies. You'll find gaps in policies and duplications. You'll find people who are eligible for 2 services and a far greater number of people who fall for the cracks and are ineligible for everything, since whoever wrote the law didn't have them in mind. There's no invisible hand that guides the formation of policy. So it is very fragmented and it is in conflict. So it's not only the policies that are fragmented, but the regulations that come out of the policies and the implementation. It becomes impossible even to find out in an area the size of New Jersey what's going on. And in our study, therefore, we recommended that at the county level, we have some kind of a clearinghouse process. We thought that might be small enough that you could find out what services and what policies were in place for human services and begin to regulate that. And there is now a planning process in place in each one of the counties for human services. But let me hit fragmentation again. Human services doesn't involve health or the elderly. It involves disabilities, children, and mental health. When we did our study, we found that policy for social services broadly was being made in 9 state departments, and I think a larger number of federal departments and agencies. And although that study was done a long time ago, I think if anything, it hasn't gotten better. And it's very, very difficult at federal level or state level for one hand to know what the other is doing in policy making. So that probably, although it's not optimal, probably the feasible way to address it is at the county level, which is small enough that we might be able to get an idea of what's going on in a county. Just to give you an example, 3 federal agencies from 3 of those big departments were all building senior citizen centers on the same block in the city where I worked, and the other side of town had none. So you see that kind of thing. And with resources as limited as they are, we don't want to see policy making at the federal level that will allow that to happen.
Policy barriers to client service.
I have come to the conclusion that there are some policies and laws that essentially help to keep people in place, to essentially maintain the status quo, that make it difficult for people to move forward and function independently. For example, some of the policies we have around public assistance. It's one thing for a client to get off of public assistance, get a job, flipping burgers or doing whatever it is. But if that parent cannot afford medical insurance and the job, possibly a minimum wage job, is not able to provide her with what she needs to make it, even working at a Walmart as an example, if they don't have health coverage, there's no motivation, there's no ability to function independently. You are pretty much forced to remain on some type of public assistance. So that's been difficult for me to really look at some of the policies that I do believe sometimes, not always, keep people, just basically maintain the status quo.
Legislative advocacy.
Hispanic Women's Center was first funded for 1 year. And at the end of the year, the funding was taken away and then they approved the program to be permanent, but was no money to fund it. So you are caught in that situation that you need to solve. And eventually, after taking an activist approach, I actually got buses with women and took them to Trenton and discussed with them, with the legislators, the Hispanic women's situation. And through that, after many discussion and visiting and contacting politicians, we were able to get permanent funding.
Using research and statistics. Role of research in needs assessment.
Research is an extremely important skill in needs assessment for anything that you're doing, from working with an individual client, with a group, with a community, with an organization, all the way up to social institution, national and international. There is a lot of data that we have, that we collect, that we don't use. And we should look at it. We should find out what the problems are. Many of them are documented already, what the needs are. And if those data don't exist, to go out and gather that information.
Role of statistics in needs assessment.
I want to say I want to make another couple of statements about the importance of research. If I'm going to go and advocate for new services, I think one of the things in social work we have a tendency to do is have a great belief that what we're doing is good and that everyone else will believe that as we do. In fact, as a professor, I make my students watch 5 reruns of All in the Family and say, that's who you're speaking to when you're selling your services. You're talking to Archie Bunker. So if I want to talk to Archie Bunker, I want to approach him with facts. And instead of saying there's a need for daycare in our town, I want to be able to say something like this. There are 2,000 children in this town aged 3 to 5. 1,500 of them have mothers who work. There are 2 daycare centers in town with a capacity of 50. And so far as the other children are concerned, 900 of them stay at home with siblings aged 10 and younger. And that's powerful.
Using statistics in program development.
If says I take a city like maybe Newark, you see how many Hispanics, how many Portuguese, how many Haitians, how many Russians that are coming a lot these days. The statistical part will help you to really develop their programs and according to their needs at that moment, because the needs change. Today is one thing and tomorrow is another.
Use of statistics in community education.
Yes, we use the updated cancer mortality rate and cancer incidence rate to promote and education the importance of the cancer prevention and early detection. However, the data due to the speciality of the Chinese community, and this data may need to modify and to meet our needs. Yeah, different cancer rate. Actually, we have a quarterly newsletter and we translate to Chinese, and sometimes we get some data from the American Cancer Society or other agency, and we try to translate to Chinese, like different rate, different statistic, or different resources from like different organization, and we translate to Chinese and provide their phone number, like their website, and they can look for themselves.
Using research in policy and planning.
One of the ways we're going to be using research and data, we're looking at enormous amounts of that for our global and our long-term care rebalancing. Just culling data, I mean, killing lots of trees, but for a good reason, in a good way. Another way we're going to be using research that I'm absolutely going to be bringing legitimate policy researchers in, national policy people, is on a health literacy initiative. It's interesting that we do a lot of things, but we're at a crossroads with what we're doing, that without legitimate research, we won't be able to further our mission and vision and the practical application of what we need to do.
Role of research in practice and program evaluation.
Okay. We also have to use research and evaluation so that we're carefully looking at our practice and what we're doing, not just at the end, but maybe all the way through. We ought to be collecting data and assessing, looking at whether the issues remain the same, looking at the strategies that we've tried, looking at the successes and failures of previous people who faced this issue, and finally evaluating what works and what doesn't work.
Studying first and second order consequences.
Another important thing I talk about in research is the idea of first and second order consequences. First order consequences being having to do with whether you have achieved your intended objective. Second order consequences having to do with whether other things have happened that you didn't plan. And the best example I have of this comes from the war on poverty, when a group of practitioners wanted to help a group of kids who were out on the street corner after school, and they wanted to get them working. Great idea. They got the kids jobs at 1.5 times minimum wage. Seemed like a great idea. Kids were off the street corner, they're working, none of the problems are going on. A month goes by. Calls start coming in from the parents. Johnny doesn't listen to me anymore. Mary says, why do I have to hear you? What had they done? They'd overturned family authority structure. These kids were now making more money than the parents. So sometimes with the best intentions, we do things trying to achieve one objective, and we do or we don't, but we also achieve some unintended things. And unintended outcomes can be positive or negative. Sometimes we have very positive outcomes, like the development of all of the monitoring equipment from the space program that now makes our hospitals much better places to be. But many of our unintended outcomes are not so positive. And when we're doing evaluation, we've got to look not only at did we achieve our objectives, but are there any other things that happened that weren't so positive, and might they be related to the intervention? Because everything, again, in social work is systemic. You can't touch any one part of the system without influencing others.
Service delivery issues. Human service delivery systems have evolved incrementally over a long period of time. Thus, it is not surprising that there are unmet needs, gaps in services, duplication of services, and fragmentation of services. There are constantly changing social problems and emerging social issues that must be addressed by human service delivery systems. Those interviewed in this project were asked to identify what they felt were the greatest issues in service delivery. Gaps, duplication, and fragmentation in policy.
And as you begin to look at the laws, you realize that laws are written piecemeal. We have an emergency, we write a law. We have another emergency, we write a law. It's kind of like a patchwork quilt, except the pieces don't fit. So as you begin to look at policies, you'll find policies in conflict, and you'll find when you get to the level of where policies talk about services, you'll find fragmentation of policies. You'll find gaps in policies and duplications. You'll find people who are eligible for 2 services and a far greater number of people who fall for the cracks and are ineligible for everything, since whoever wrote the law didn't have them in mind. There's no invisible hand that guides the formation of policy. So it is very fragmented and it is in conflict.
Limited resources.
A lot of people they are diagnosed with cancer after they have free screening. But after that, they need a further treatment. But they have to pay the medical bill by themselves since they don't have insurance. And from that, people call us for further support, but we can do nothing. So we feel very frustrated about this. And the other one is because of the culture and background, many Chinese Americans, they have less willingness to contribute their time, money, and energy on community services. So I think we need to make more efforts to encourage people's willingness.
Probably the greatest challenges are financial. We have a longer school day, a longer school year. Our teachers are in there for 8 hours a day, and then they're still taking work home like all educators and social workers and professionals do. And just to compensate them appropriately for that, to be able to run the support programs that the students need, it's definitely financial is the biggest obstacle. And we have a lot of dedicated professionals who are working there because they believe in what they're doing and care about what they're doing. And it's really a case where their avocation is their vocation, because they certainly couldn't be paid enough for all the time and effort and heart they put into their jobs.
I hear all the time from single parents that just don't make enough money to live, and then make too much money to qualify for medical benefits, health insurance, housing assistance, and it just seems impossible to get through the system. And I've tried to do that myself. You know, I said, well, let me make a few calls, and it's so frustrating. And because there is nothing available, and especially health insurance, because I think now what's happened is we provide health insurance to the children, but not to the parent. And so the children are covered, but the parent, you know, they have a toothache and they can't go to the dentist because, you know, they don't have the money to go and they have no benefits. And it just doesn't seem right. And I think I hear it all the time. I hear it all the time.
Stigma attached to services.
Well, I think the greatest challenge is the fact that they see me as a shrink. So that has a negative connotation. And I think that they're then resistant to coming to see me. What I have done to change that is I see every freshman individually. I do a genogram, I talk to them, I encourage them to come to see me if they have any problem or any, even if it's not a problem, it's something they just want to discuss and work it through, then I'm there for that. And that has helped greatly. And they get very surprised with the genogram too. The other thing that you find from a genogram is I found that relatives have been shot, stabbed, incarcerated, whatever. So I get to know a lot about them just by doing the genogram. And they're generally amenable to that. We find diseases if they have diseases in the family. A lot of them have sickle cell anemia. And we then encourage them to go to the proper healthcare providers. So we do a lot to encourage them to see me. And once they get to know me through that process, then generally they're less likely to be resistant if they need to come and see me.
And I don't know if this is the place to talk about the continuing stigma about seeking help. We don't think it's okay. And that's a tremendous barrier.
Okay, I feel that there's still a lot of stigma attached to persons that are recovering, persons that have a problem with addiction, substance abuse, or some of the other addictions that are maybe, food or sex or whatever, that there's so much stigma attached. There's stigma attached to having a psychiatric diagnosis. Whereas I guess studying years ago, I felt like we were beyond that. But it upsets me very much that still there seems to be, in our society, a lot of stigma on these individuals that are just wounded. They're just wounded.
International nature of communities.
But for me, I think we have to look at the communities as international communities these days. We cannot do social work as well, the 30s or the 40s. Our communities are international communities these days, especially the urban areas. The rural, you find a lot. You go through many places and you see people speaking different languages. So we have to accept that.
Limited consumer input into services.
I'm staying with the community organizing here. The greatest challenge that I see is that I'm going to compare social work to McDonald's for a minute, which is one of the analogies I use in class. If I'm going to McDonald's or Burger King or wherever, I go in, I pay my money, I get my hamburger. If I'm unhappy, I can take my money and go somewhere else. But in social work, generally speaking, the consumers don't pay for the services. So we've got the money for the services coming from over here and the consumers over there. And the people who pay are the ones who feel that they ought to have control of what the agencies do, and the agencies respond to that since they want to survive. The people who are making those decisions are very far removed from the people who are getting the services, and sometimes very much out of contact with what the issues are. They're thinking of issues that they care about or issues that they would like to see resolved. They're trying to impose their values on the community. And I think one of the biggest challenges is how do you get a communication between those groups so that those who have the power and money see the needs, understand the needs. Research, by the way, is really helpful. And see the needs not only as the needs of those people, but as the needs of our community that are important to all of us. If we have kids in our town who are not learning to read, who are reading at a second grade level, maybe that's their problem now, but when those kids graduate with a social diploma, it's going to be all of our problems, since they will be ill-prepared to get jobs. So that's the biggest challenge.
Accountability.
If I look at the systems, the agencies that provide the service, it would be that there'd be far more accountability. So that if there are serious mistakes made, for example, where lives are lost, children are permanently damaged, that there is accountability, not necessarily the low-level line worker doing it, but that these things need to really run up the flagpole to people who actually conceptualize and implement these policies, not just the people that follow the directions. So for me, having watched over the years many, many instances of policies, programs that just did not work for certain parts of the population, and seeing low-level people just lose their job because something happened, I really think there needs to be far more accountability. I think it's important for people to say, look, I made a mistake. Here's what I can do at this point, or just assume responsibility as opposed to pushing it off on everyone else.
Okay. The one change would be for consumers to have more input into the services that they receive. So unless consumers can be brought to the table in some way, whether it's partly through research data, but I think also in having a voice, I think that's the only way we're going to resolve that issue. I think we have senior citizens groups now that are going to make their voice heard, and that may be the way that will happen.
Current social problems. Social issues and problems are constantly changing and evolving. In this project, respondents were asked to identify the greatest current areas of unmet need. Substance abuse.
I think probably one of the most salient issues are substance abuse and children, or when parents are substance abusers, and I think that has, that's a big issue.
Working in addictions, and I'm working with individuals who have been using a number of different types of substances for a long period of time, who also have underlying issues. Trying to identify what the most important thing is, and sometimes not knowing that the client is not telling the truth, and working with the client who's really not ready and thinking they're ready and thinking that you're moving along. So no matter how much experience you have, there are going to be individuals that present problems to you that are very complicated and take a lot of different resources.
Issues of race.
I know that for myself in particular, it's important to me to be treated as an equal. I've had a few experiences where, one in particular, I walked into a classroom several years ago, again at another university, put my bag and everything on the desk, and a white student came up to me and said, I think the professor will be here soon, you probably need to move your things now. So I just smiled and kept moving. And then I came back in a few minutes and put my name on the board, and I thought she was going to just pass out. But to me, sometimes people make an assumption based on my skin color that this could not possibly be the professor. I've also had instances of going to citywide and state agencies and going in a receptionist assuming I'm here to fill out an application for public assistance when I'm actually going to meet with the commissioner for something. So I would say yes, being viewed as an equal and being treated with dignity and respect and not making an assumption that I'm something I'm not. And I'm sure clients and students feel the same way.
A girl came in and she refused to take off her wave cap, and that is not allowed in school, which I totally agree with. But something had happened that day to her hair, and she was so embarrassed that she wouldn't take it off. And I said to Mary Jo, I said, you know, our hair is so different. We are talking here, not even apples and oranges. It is so different. And once our hair gets wet, it's not like we can shake it out and it's going to be okay. You have to go through the process of, I don't straighten my hair, but many people straighten their hair, and it's a process and it takes hours. So here, this young woman showed up at school. She came, but she was sent home. And that was the one, that type of thing, I think, needs to be adjusted a little bit. And I understood policy is policy, and I agreed to some great extent, but there are extenuating circumstances, and they are just different things with different populations, and that's one. Our hair is a whole other thing. So it can be as simple as that, but it's not a simple thing. Do you know what I mean?
Caregiving.
Last year I took a sabbatical and got involved in some things that I wouldn't ordinarily do. And one of the issues in which I got involved was the issue of caregivers of the elderly. Something I hadn't thought very much about until I began to work with them and realized what a monumental service caregivers of the elderly provide, and how they're doing this for their family members or friends without compensation, with very few resources. Those caregivers are very, very much at risk for burnout, which is kind of what we found. You kind of, you see that if you work with a group of these folks. It's a 24/7 job. And if there aren't respite services and other resources and supports available, then it becomes impossible for that caregiver to continue. Some people find it in their religious faith. Some find it through services through a church or a neighborhood group. But society as a whole is going to have to react to this issue as the people receiving care increase in numbers with the increasing number of senior citizens in our population. So that was one issue of which I became aware in that population. Now, at the same time that seniors are caregivers and care recipients, the other issue also related to seniors is the growing number of grandparents and great-grandparents who are raising their grandchildren. And that was another study I worked on last year, was looking at grandparents and great-grandparents who were caregivers. I was involved in focus groups with about 70 or 80 people during this study that I conducted. And there were people in their upper 70s, some with very, very serious health problems. In addition to the fact that they're caring for children when their own health is failing, they ran into issues like this. They were living in senior housing. When the children moved in, they're no longer eligible to stay. They have to move out. Or they get a subsidy for caring for their grandchildren. That puts them $5 over the limit for food stamps, and the total amount of money at their disposal is now less. Or some of the programs count their personal income in determining benefits for the children, who are not their responsibility to support. So you have people on fixed income whose resources and income is not going to be growing, who have their own health problems, many of them limited access to health care for themselves, now caring for grandchildren and great-grandchildren, as many as 6 or 7 in a family in some cases. And if society, again, does not come in to look at that issue and address it and put supports in place, in either case, there's going to be a much greater social and economic cost to society in having to have those children or those seniors receive care in another way. So I guess my hope is that we begin to look at that and to develop community-based alternatives that will work for those unmet needs.
Domestic violence.
I guess for me personally, it has been seeing people not be able to achieve those goals. The most painful, frustrating, difficult challenges have been women, for example, who are living in abusive, dysfunctional family settings with abusive spouses, partners, husbands, and are unable to make the changes necessary to start leading healthy, functional lifestyles. And knowing that there are children there. Yes, of course, the children can be removed, and we do see this happen sometimes. But I always worry about and still wonder about the person who is still experiencing the abuse. So not seeing people achieve the goals is frustrating and difficult. And sometimes these people do die as a result of choices that they have made to go back into the situation. One specific example, I had a former client one time who had been badly beaten a number of times, and the last time she wound up in the emergency room, fractured skull, you name it, head bandaged up, and she made the decision to go back. We went to court, and the judge was ready to sentence, and she looked over at her husband and made the decision to drop the charges. And she wound up being killed. And I remember the last thing I had the opportunity to say to her is, you know, I'm really concerned about you. I don't know how much more your body can take of this. And she said, I know, but I love him. So those types of situations are very, extremely frustrating. You'd like to just scoop these people up and take them off someplace, but that's not enough. And they do have a right to live their lives the way they want to. So.
Suicide.
If you have a client who's suicidal, you are checking your messages frequently. You're contracting, you're attempting to have some assurance of well-being when you really can't. You're seeing people for 50 minutes in a week at best, and they have the rest of the week to make all kinds of choices. And that's where I go back to the strength of the basic relationship and the trust, and the fact that sometimes you have to trust somebody saying that, no, they're not going to harm themselves this week. So those are significant challenges to the clinician.
Housing issues.
I think these days, housing is a tremendous unmet need because there's a lot of building. You see every community have constructions, but they all for very expensive homes. And the urban areas are losing a lot of housing for other construction, business construction, but it's no construction for low-income families. So that's a very difficult need to fulfill these days.